going on, besties? Today we're going to be talking about everything you need to know all in one place when it comes to sodium electrolytes, hypernatremia, and hyponatremia. Let's get started. If you're new here, I'm Nurse Cheung, armed with a master's degree in nursing education and over a decade of teaching experience, here to decode all the mysteries that we're going to be learning about with this mineral today. So let's start with the basics. Pathophysiology. Sodium, symbolized by Na, is an extracellular mineral, absolutely vital for several key functions in our body. You can think of sodium as the director, orchestrating everything from how much water our cells are going to hold to how nerves communicate and even how our muscles contract. It's not just about adding flavor to our food. Sodium is essential for guiding the overall activities that keep our body's systems running smoothly. A cool memory trick to help me remember what sodium does is I like to think of Na as being necessary for activity because it's essential for nerve and muscle functions. In terms of interaction, sodium does not work alone. It's closely regulated with potassium and chloride to maintain cellular function and control our blood pressure. So what's considered normal? Sodium levels found inside our blood should typically be between 135 to 145 milliequivalents per liter. These levels can be influenced by several factors like what we eat, how much we drink, and even changes in our hormone levels. Another cool memory trick to remember the normal levels is I like to think of 135 to 145 keeps cells alive. It's really an easy way to remember the normal sodium range. So where can we find sodium? Sodium is predominantly an extracellular mineral, which means that it primarily resides outside of our cells. Typically, whenever we observe higher normal numbers for any electrolyte like sodium, it indicates that the ions are primarily found in the extracellular spaces. So let's take a closer look at how sodium functions, starting with how it maintains fluid balance. Sodium is the primary ion in extracellular fluid, and it plays a key role in regulating osmotic balance across cell membranes. This ultimately means that sodium helps maintain the balance of water between the interior of cells and the surrounding fluids. Remember, water follows salt. Water is naturally drawn to where sodium hangs out. It's similar to how you might crave water after eating a really salty meal. With high sodium levels in the bloodstream, water from inside our cells are going to come rushing out, and this is going to lead our cells to shrink. When sodium levels can become excessive, it can lead to things like edema, where fluid is going to accumulate in our body's tissues. As more and more fluid begins to build up, that excess is going to be stored in areas like our legs, our ankles, and our feet, and you're going to see a lot of noticeable swelling. In more severe cases, this fluid accumulation can end up in the lungs, resulting in pulmonary edema, which impairs our breathing and our oxygen exchange. On the flip side of that, when there's a scarcity of sodium in our blood, the water feels a little bit lonely and it starts to move towards where there's still some sodium left. Even if there's just a small amount of sodium inside of our cells, the water is going to start to move in, causing the cells to swell. Another function of sodium is it directly influences blood pressure and blood volume. As water starts to enter the vascular space, as we talked about with our hypertonic example, it increases the total volume of blood within the circulatory system. This increase in blood volume raises the pressure found within our blood vessels. So what exactly is blood pressure? Blood pressure is defined as the force exerted by circulating blood on the walls of the blood vessels. It directly influences both the amount of blood and the resistance encountered from vessel walls. So if we see an increase in the volume of blood due to that high sodium levels, the blood is going to exert more pressure against the vessel walls, leading to elevated blood pressures, also known as hypertension. However, if we're seeing lower than normal sodium levels in the extracellular space, then this could lead to a reduced blood volume, leading to hypotension, known as low blood pressure. In addition to fluid balance and blood pressure, sodium plays a critical role when it comes to transmitting nerve signals through action potentials. Sodium ions are crucial for generation and propagation of action potentials in neurons. When a nerve signal is initiated, the sodium channels that are in the neuron's membranes are going to open, allowing sodium ions to rush into our neuron. This influx of sodium causes the electrical potential inside the neuron to become a little less negative. This process is known as depolarization. After the area of the neuron depolarizes, we're going to move into signal propagation. What happens here is that the adjacent sodium channels are going to open up in a wave-like fashion along the neuron. Ultimately, this is going to lead to propagation, where that electrical signal is going to move down the length of our nerve fiber, where it's going to ultimately reach the synapse. Here is where the neurotransmitters can be released, thereby continuing that transmission of the cell signal onto the next neuron. And last but certainly not least, we have muscle contraction. Sodium's role in muscle contraction is closely tied to its function when it comes to nerve activity. Muscle contraction begins when a motor neuron releases something called acetylcholine, and it releases it here at the neuromuscular junction. This is what's going to trigger the opening of those sodium channels in the muscle cell membrane. The influx of sodium depolarizes the muscle cell membrane, which then triggers the release of calcium ions from the sarcoplasmic reticulum inside of our muscle cells. The increased calcium concentration inside of the muscle cells are going to lead in that interaction between our actin and myosin, which is responsible for muscle contraction. So you may be wondering, how exactly is sodium regulated? This is achieved primarily through our kidneys, which adjust sodium level concentrations by either excreting or reabsorbing it depending on what the body needs. Hormones regulated by our endocrine system like aldosterone and antidiuretic hormone, also known as ADH, also play a pivotal role in this regulation. Aldosterone, for example, helps regulate sodium reabsorption and potassium excretion in the nephron of the kidneys. A cool memory trick is to remember that aldo stores Na. Aldo meaning aldosterone, who is in charge of storing sodium Na inside of our body. And then of course we have our good old antidiuretic hormone, also known as vasopressin, primarily regulates water balance in our body. So what ADH does is it acts on our kidneys and it's going to increase water reabsorption, which decreases urine output and helps dilute the blood's sodium level. Hence the name antidiuretic. It means against urinating. You can think of ADH as the body's aqua defender. What it's going to do is it's going to hold on to the water when the body senses that things are getting a little bit too salty or if there's not enough blood volume. And then we have the sodium-potassium pump. This also plays a pivotal role in balance of sodium as well. So what this pump actually does is it moves sodium ions out of our cell and potassium ions into the cell. This is essential when it comes to maintaining that resting membrane potential, which is the electrical charge difference across the cell membrane. For every 3 sodium ions that you're going to see pumped out, you're also going to see 2 potassium ions being pumped into the cell. This is going to create an electrochemical gradient. This active transport process requires ATP, which is the energy we need in order to make this process happen. It ultimately highlights how energy intensive it is to maintain electrolyte balance inside of our body. If you're new here, I'm Nurse Cheung, armed with a master's degree in nursing education and over a decades of teaching experience. So when we're talking about hypernatremia, we're talking about hyper meaning high, NATR means our sodium, that's the standard use of sodium. And then we have emia, which means in the blood. So hypernatremia means we have high sodium in our blood. And we're usually looking at sodium levels that are greater than 145 milliequivalents per liter. So you might think that sodium is just a thing that we sprinkle on our food, but when there's way too much of it in our bloodstream, it can actually create serious problems. Hypernatremia usually happens in one of 2 ways. This occurs when the body loses more water than sodium. Think of situations like excess sweating, vomiting, or even conditions known as diabetes insipidus. But hypernatremia doesn't always come from losing water. Sometimes it's actually caused by the body retaining too much sodium. In these particular cases, water follows sodium. So they're going to move outside of those extracellular spaces, and they're going to cause a lot of things like fluid overload and edema, which is just basically a fancy way of saying that there's swelling in our tissues, either in our legs or in our lungs. Conditions like heart failure or kidney disease can make the body hold on to more sodium. This ultimately leads to this specific kind of hypernatremia. So what we're going to do is we're going to break down exactly what hypernatremia is, the causes behind it, and how we manage it in clinical practice based on these two scenarios. So what are some common causes when it comes to hypernatremia? First, we're going to start with our water loss and dehydration category, and we're going to use the acronym MODEL. First up, we have M, and that stands for medication or meals. When you take in too much sodium from salty foods, or maybe even certain IV fluids, it doesn't just overload the body with salt, it throws off your water balance entirely. In cases of water loss and dehydration, your body may not have enough water to keep up with all of that sodium. Without enough water to dilute that sodium, it becomes concentrated in your blood, leading to hypernatremia. So the next time that you're reaching for those extra salty snacks, remember to stay hydrated, especially if you're sweating or losing fluids. Next up, we have O, which stands for osmotic diuretics like mannitol. Osmotic diuretics work by increasing the amount of water that's going to be excreted by the kidneys, but they do it in a unique way in comparison to other diuretics. These diuretics primarily affect water excretion rather than sodium or other electrolytes. So more water is lost in the body, which helps reduce fluid overload, but it can also lead to hypernatremia if water loss exceeds sodium loss. Now moving on to D, which stands for diabetes insipidus. Diabetes insipidus, also known as DI, is a condition where the body cannot properly regulate water balance, leading to excessive thirst and large amounts of diluted urine. This happens because antidiuretic hormone, also known as ADH or vasopressin, is either not produced in sufficient amounts, where we see in central DI, or the kidneys do not respond to it properly, as we see with nephrogenic DI. Typically, ADH helps the kidneys retain water by making the kidney tubules more permeable to that water. However, in diabetes insipidus, when ADH is lacking or ineffective, the kidneys fail to conserve that water, causing excess water loss through our urine. And you've guessed it, E stands for excess water loss. Whether it's from sweating, diarrhea, or vomiting, when the body loses a lot of water, the concentration of sodium in the blood increases. This is especially common during heat waves or when you're sick. That's why it's so important that you drink a lot of fluids in both of these situations. And finally, L stands for low water intake. If you're not drinking enough water or you have NPO status while you're in the hospital, dehydration can set in quickly, concentrating the sodium that's found in your blood. Next up, we have fluid overload and edema, and we use the sentence, "Some can't live too happy." Starting with the S in some stands for sodium intake. Just like I mentioned earlier, whether it's from diet or IV fluids, too much sodium can increase the body's sodium levels. However, what's different about this scenario is that we don't have fluid loss, so water is going to follow sodium, leading to fluid retention in our extravascular spaces, causing hypernatremia. And next up, the C in can't stands for corticosteroids. Some medications like corticosteroids and certain blood pressure medications can make the body hold on to sodium, causing fluid retention and raising sodium levels. Next up, we have liver and kidney disease. When the kidneys can't properly filter out sodium, or if liver function is compromised, sodium is going to build up in our bloodstream. This kind of sodium retention is going to lead to fluid overload and swelling, especially in our lower extremities. The T in 2 stands for the heart, more specifically heart failure. When the heart is unable to pump blood effectively, sodium and water is going to build up in the body, leading to fluid retention, edema, and you guessed it, hypernatremia. And finally, the H in our happy stands for hypersecretion of cortisol, like we see in Cushing's syndrome. In this condition, too much cortisol causes the body to retain sodium, leading to fluid retention. It's a hormone issue that can seriously impact the body's electrolyte balance. So what signs and symptoms are we going to see with this condition? So starting with the effects of the neurological system, we use the acronym FRIED in order to remember the different symptoms here. The F stands for fever. So your body gets dehydrated in water loss types of situations, and it causes the loss of water from the cells, including those that are found in our brain. This can actually trigger inflammatory responses leading to the fever. So you'll see this more often in water loss when it comes to hypernatremia. Next up, we have restlessness and irritability. This is actually an early sign, and it's your brain's way of saying that you're running low on water. What's interesting is that when our brain cells shrink due to dehydration, it messes up our normal brain function, causing people to become a little bit more agitated. As those brain cells continue to shrink from that lack of water, it starts to really mess up with that normal electrical signals that we would typically see. So this is going to lead to disorientation as well as confusion. Our I and our E stands for increased fluid retention and edema. Edema is actually one of the most common things that you're going to see when it comes to fluid overload. So I want you to think about it. When the body retains too much sodium, water is going to follow, leading to fluid buildup in places like our legs, ankles, and even our brain. And then we have D, which stands for decreased level of consciousness. You can even see seizures as well as coma if hypernatremia gets really severe, especially in water loss cases. So the brain cells are going to shrink enough to cause serious problems, and you could potentially see somebody go into seizures and coma depending on how severe that is. But here's the deal. If you have a patient that is experiencing seizures, decreased LOC, or even coma, that means we've missed something along the way. There should have been some early signs prior to them experiencing this. When it comes to our musculoskeletal system, hypernatremia can lead to muscle twitching, weakness, and cramps. And here's why. Muscle contraction and nerve signals rely on a balance between sodium and potassium. These two electrolytes work together with something called the sodium-potassium pump, which helps regulate electrical impulses for muscle contraction. When there's too much sodium in the blood, especially when we have water loss on top of that, this pump gets thrown off balance. This can lead to muscle weakness, twitching, as well as cramps. Remember, the more sodium I have, the more activity you're going to see. The Na, which stands for sodium, means necessary for activity. You might also see things like hyperreflexia, which is just a fancy way of saying overactive reflexes, or even tremors, because the nerve signals are highly disruptive. If hypernatremia comes from fluid overload, you could still see these symptoms, but they're going to be less pronounced at first, since that extra fluid keeps things balanced for a little bit longer. All right, now we're going to move on to the heart, and this is where things get really interesting. With hypernatremia, you can see things like tachycardia, which is a fast heart rate, postural hypotension, which is a drop in blood pressure when you stand up, decreased blood pressure with water loss, as well as jugular vein distension, also known as JVD, and fluid overload. But why do these things happen? So in water loss, your blood volume decreases, meaning that there's less fluid circulating through your blood vessels. What the heart's going to want to do is it's going to want to compensate for that lack of fluid. So it's going to start pumping faster, leading to tachycardia. At the same time, you may experience postural hypotension, which is that feeling when you get dizzy after standing up. This is because there's not enough blood volume to help maintain normal pressure when you make position changes. But with fluid overload, we have the complete opposite problem. What you're going to see is you're going to see jugular vein distension, where the veins that are found in your neck are going to start to swell because there's too much fluid. This extra fluid puts pressure on your veins, and it's ultimately going to cause strain on your heart. And finally, let's talk about our renal urinary system. In cases of water loss, like we see with diabetes insipidus, the kidneys can't hold on to water properly. In diabetes insipidus, you're going to pee and pee and pee and pee. This condition is going to lead to excessive urine loss, also known as polyuria, which is actually going to make hypernatremia worse because you're losing even more water while sodium levels are staying high. On the other hand, in fluid overload, the kidneys might not be producing enough urine due to heart or kidney failure. That's going to lead to oliguria, which is a low urine output. This happens when the body retains sodium and water ultimately worsening the symptoms. So which signs and symptoms can we catch early and which ones are going to be a little bit too late? So the early signs are primarily going to be neurologically. We're going to have irritability and confusion. Musculoskeletally, you're going to see a lot of that excitement. So a lot of muscle weakness as well as twitching. And then with the cardiovascular system, in order to compensate for what's going on, you're going to see that tachycardia and that postural hypotension. These early symptoms are the body's first attempt to cope with those rising sodium levels. But if things get worse, we can start to see those more late signs, including severe neurological effects like seizures and comas, more serious cardiovascular symptoms, including severe low blood pressure, as well as that jugular vein distension. The kidneys are not going to be able to function appropriately, so you're going to see the oliguria, and ultimately, these are going to be the late signs and conditions that are going to be very critical and need immediate attention. So what are we looking at when it comes to diagnostic testing? So first up, we're going to be looking at specific labs when it comes to our green tube. We're going to start with serum sodium levels because that's going to directly tell us how much sodium is floating around inside of our bloodstream. Like I mentioned before, a normal sodium level should be between 135 and 145. Anything above 145 means we're looking at hypernatremia. Then we have serum osmolality tests, which is going to measure how concentrated our blood is. This is really important for our dehydrated patients because it'll tell us if there's not enough water to balance out the sodium. If the sodium level is high, we'll likely see an elevated osmolality too. Typically, anything above 295 is considered high. We're also going to run a blood urea nitrogen as well as a creatinine to see if the kidneys are working appropriately. If these levels are elevated, it could tell us that the kidneys are not filtering properly, which could be contributing to our high sodium. A normal BUN should be between 7 to 20, and a normal creatinine should be between 0.6 to 1.2. Next up, we have our lavender tube, and that's where we're going to run something called a CBC, also known as a complete blood count. And this is going to check for dehydration, like elevated hematocrit and hemoglobin levels. These numbers will typically rise when the body's losing too much water. Now we have to ask ourselves, why would these numbers rise if we're losing too much water? Well, here's the thing. When you're dehydrated, whether it's through sweating, vomiting, or conditions like diabetes insipidus, the body starts to conserve whatever fluid it has left. This means you're going to have less water in your blood, which is going to make the components of your blood, like your red blood cells and your hemoglobin, appear more concentrated. Think about it like making soup. If we boil off all the water, the remaining ingredients are going to become more concentrated. The same thing happens with our hematocrit and our hemoglobin. When the blood volume decreases due to dehydration, the proportion of red blood cells to the rest of the blood is going to increase. So you're going to see a rise in those numbers when you look at your lab results. And lastly, we're going to look at our gray tube, which is going to test our glucose levels. Glucose levels are important, especially in patients with diabetes. High glucose levels can actually lead to water loss through our urine, so that will ultimately make our hypernatremia worse. When we're looking for normal levels with glucose, we're usually looking between 70 to 100 if the patient has been fasting. So what potential diagnostic testing could we see with hypernatremia? Sometimes we're going to need imaging to confirm what's really going on. A chest x-ray can actually help us see fluid buildup in the lungs, especially if we're suspecting fluid overload. If the patient's experiencing severe neurological symptoms like we see with seizures and coma, we're most likely going to be ordering a CT or an MRI to check if there's any brain swelling taking place. So lastly, we're going to be looking at the interventions that we might be performing for hypernatremia. We use the acronyms sodium, restrict, depending on which condition we're looking at. Starting with water loss and dehydration, we want to restrict the intake of sodium. Ultimately, if you're trying to lower sodium levels, it just makes sense that this patient might have to cut back. The recommended daily intake of sodium is less than 2,300 milligrams per day. So we're going to guide the patient on how to avoid high sodium foods like processed snacks, canned goods, as well as fast food. We also really need to be encouraging oral fluids, especially free water. When the body is losing too much water, we want to replenish that water without adding any more sodium to the mix. So we're really going to want to push our patients to drink water regularly throughout the day. Daily weights are simple, but they're also a really important tool. We really want to be monitoring for fluid loss or retention, and here's why. For every 1 kilogram that the patient gains, we're adding about 1 liter of fluid to the body. So if we see this big jump in weight, it means the patient's most likely holding on to too much fluid. You really want to make sure you're keeping an eye on that scale. Then we have intake and output, and it's exactly what it sounds like. We're going to be keeping track of everything that the patient drinks and everything that they excrete. It helps us measure how much fluid is staying in the body and how much of it is leaving. This is really crucial in preventing complications from either dehydration or overhydration. Sometimes oral fluids isn't going to be enough, and that's when we're going to have to start looking at hypotonic IV solutions like 0.45% saline. Hypotonic solutions have less sodium than the blood, so they can help replenish water while also lowering our sodium concentration. But we need to be very careful when we're giving this kind of IV medication because too much can actually cause swelling, especially in the brain. And lastly, of course, we want to monitor vital signs, especially our heart rate and our blood pressure, because dehydration can really mess those up. We also want to keep close tabs when it comes to our neurological status, especially for early signs of confusion and irritability, and we want to make sure we're running those lab tests to check the sodium levels and everything that's associated with it. Now let's switch gears and talk about fluid overload and edema when it comes to hypernatremia. Just like with water loss, we really want to make sure that we're reducing that sodium intake and fluid overload. Too much sodium leads to fluid retention, which is exactly what we're trying to avoid. We're also going to want to make sure that we're evaluating for edema by checking the swelling in our tissues. This evaluation can include checking our lung sounds for crackles, which lets us know that there's a fluid buildup in the lungs. We're going to be watching for that weight gain like we talked about before, and we're also going to be checking the neck for jugular vein distension, which is a sign that the body's retaining too much fluid. Once again, we're using strict intake and output. We want to track how much fluid is going in and how much we got coming out. With fluid overload, the patient may have edema, which increases the risk of having skin breakdown. So to prevent pressure sores from occurring, we really want to make sure that we are turning and repositioning our patient frequently, especially if they are bedbound. In some cases, we may need to take it a step further and actually restrict fluids. This means carefully limiting the amount of water or other fluids the patient drinks, especially if they're retaining too much. If fluid overload is severe, we're most likely going to be looking at initiating some kind of diuretic, more specifically a loop diuretic like furosemide, also known as Lasix. These medications help get rid of excess body water and sodium by increasing our urinary output. We're also going to want to keep a close eye on circulation. We're going to check for peripheral pulses as well as capillary refill, which is how fast blood returns to the tissue after pressing into the skin. Poor circulation can be a sign of fluid overload, and that fluid overload is most likely affecting the heart and our blood vessels. And lastly, we cannot forget about education. It's one of the most important things that we do as nurses. It's super important that we teach our patients how sodium can affect their condition. We're also going to explain why they need to reduce their sodium intake, how to read food labels for sodium content, and tips for staying hydrated without overloading on fluids. Empowering our patients is the best way that we can help them take control of their health. So let's break down hyponatremia. So just taking a look at the word hyponatremia, we have the prefix hypo, which means low. We have natrium, which is a Latin word meaning sodium. Typically, you'll see it listed as Na, but that stands for sodium. And then we have emia, which stands for in the blood. So if you put it all together, we have low sodium in the blood. A normal concentration of sodium should be between 135 to 145, but when we're talking about hyponatremia, we're looking at concentrations that are less than 135 milliequivalents per liter. Now here's the key. The sodium concentration in the blood isn't just about sodium itself. The balance happens between water and sodium levels found in our body. If one of these things get out of whack, the sodium concentration is ultimately going to change, and that's where the problem starts. Hyponatremia is generally divided into three categories based on the body's water volume status. So let's get started with hypervolemic hyponatremia. This is where we have a total body water increase significantly, but the increase in sodium is going to be much smaller. This imbalance between water and sodium is ultimately going to lead to low sodium concentrations. You'll see this in conditions like congestive heart failure, kidney failure, liver failure, as well as excessive infusions of saline. Typically, you're going to see where fluid is ultimately going to leak out of the blood vessels into the interstitial spaces, causing edema, especially around the ankles. Even though the body has more water overall, the circulating volume in the blood vessels, or the blood flowing and doing its job, is going to be reduced because much of that water has moved into the interstitial spaces. The body needs more fluid back into the blood vessels, so it's going to trigger the release of antidiuretic hormone, also known as ADH, which makes the kidneys hold on to water. At the same time, the body is going to release aldosterone, which is going to help us retain sodium. But remember, water always follows sodium. So what's the result? The result is that the body's going to retain even more water than sodium, leading to hyponatremia despite all of that extra fluid around. The second category is hypovolemic hyponatremia, which happens when there's a decrease in total body water, but a significant decrease in total body sodium. You're often going to see this condition in situations like diarrhea, vomiting, and NG suction, where the cells lining our gastrointestinal tract are going to pump sodium into our digestive juices. But here's the catch. Instead of reabsorbing that sodium, it's ultimately going to be lost when the digestive contents are expelled from the body. We also have situations when it comes to diuretic medication. They're often called water pills because these medications make your kidneys work overtime to get rid of excess fluid by increasing urine output. While the kidneys are flushing out water, they're also causing the body to lose more sodium. Specifically, some diuretics like thiazides are going to act on the kidney's renal tubules, blocking sodium reabsorption. This means that sodium is going to get excreted in the urine instead of being recycled back into the bloodstream. Since water tends to follow sodium, this process pulls even more fluid out of our body. Over time, if too much sodium is lost, it can lead to hypovolemic hyponatremia, where there's going to be a drop in both water and sodium, but sodium decreases more significantly, tipping that balance. You can kind of think of it like overwatering a plant and washing away all the nutrients in the soil. Eventually, the plant doesn't have enough it needs to thrive. The same thing happens to our body when we lose sodium and fluid. And lastly, we have a more unique scenario called cerebral salt wasting. Cerebral salt wasting is a condition where the body loses too much sodium due to an issue in the brain, often after an intracranial injury such as trauma, meningitis, or a stroke. So here's how it works. The injury disrupts the normal communication between the brain and the kidneys, specifically the sympathetic nervous system, which helps regulate sodium and water balance. This disruption is going to cause the kidneys to go into overdrive, excreting too much sodium into the urine. And because water tends to follow sodium, the body's also going to lose a lot of fluid. This ultimately results in hypovolemic hyponatremia, where both the sodium and water levels are going to drop and sodium is going to decrease more significantly. It's as if the brain is tricking the kidneys into thinking that there's too much sodium, so they flush it out when in reality they desperately need it. And lastly, we have our third category of euvolemic hyponatremia. This one can be a little bit tricky because despite the name, it's not actually about everything being normal. This happens when the body's sodium levels are normal, but there's an increase in total body water, which is ultimately going to dilute the sodium that's found in our blood. The reason it's called euvolemic is that there's an extra water that doesn't spill into the interstitial spaces, so you don't see edema or other signs and symptoms like you would see with fluid overload. Now, depending on the type of urine that we're dealing with, we can figure out the kind of cause. If our urine is more dilute, then that usually means that the body is trying to get rid of excess water. Things like adrenal insufficiency and too much water intake can both cause euvolemic hyponatremia, but they do it in slightly different ways. In adrenal insufficiency, the body doesn't produce enough of the hormone aldosterone, which is ultimately responsible for holding on to sodium. Without enough aldosterone, sodium is going to get lost in the urine, but water levels stay the same or even increase, leading to diluted sodium levels in our blood. On the other hand, when someone drinks too much water, also called polydipsia, that sheer amount of water is going to overwhelm the kidney's ability to excrete fast enough. This excess water is going to dilute the sodium that's found in our blood, even though the total amount of sodium hasn't changed much. In both cases, the sodium concentration drops because there's too much water relative to the sodium. On the other hand, if the urine is too concentrated, it can be due to too much antidiuretic hormone being released, which we call SIADH, or syndrome of inappropriate antidiuretic hormone secretion. In situations like SIADH, it causes euvolemic hyponatremia by making the body hold on to more water than it actually needs. The antidiuretic hormone is released when it shouldn't be, or it can be released in amounts that are too high. ADH's one job is to signal the kidneys to retain water, which it does very effectively. So since that extra water is mainly staying in the bloodstream and not leaking into the tissues, the person appears to be a normal volume status, also known as euvolemia, even though the sodium is critically low. Hypothyroidism is also a cause of concentrated urine in this particular situation, though we don't fully understand why. Either way, the end result is too much water, not enough sodium, and the blood sodium level is out of balance. So what are some other common causes when it comes to hyponatremia? We use the mnemonic old salt wash. Starting with O, we have overhydration. And in this particular situation, it's when we drink way too much water or we receive excess saline infusions. This fluid is going to dilute the sodium that's found in our blood, leading to hyponatremia. And next up we have L, which stands for liver failure. And this means that the body is going to struggle to manage fluid. This is going to lead to retention in the tissues and low sodium levels in our bloodstream. This ultimately happens because the liver can't produce enough proteins to keep fluid in the blood vessels, causing this dilution effect. And next up we have D, which stands for diuretics, also known as water pills. And what they do is they're going to make you pee more. So while this is great for getting rid of excess fluid, they can also cause you to lose too much sodium in the process, ultimately leading to hyponatremia. And then for S, we have SIADH, which is syndrome of inappropriate antidiuretic hormone secretion. And we talked about this a little bit before, that SIADH makes your body hold on to water when it really doesn't need to. And then A stands for adrenal insufficiency, where your body doesn't produce enough aldosterone, which is a hormone that is crucial when it comes to retaining sodium. This means that you're going to lose sodium through your urine, which drops your sodium levels too low. And then we have L, which stands for loss in the gastrointestinal tract. So this condition, like we talked about before with diarrhea, vomiting, and NG suctioning, is going to ultimately lead to a decrease in sodium. That digestive tract is going to pump sodium into the fluids to help with digestion, but if the fluids are lost, the sodium's also going to go with it. We have thyroid issues for our T, also known as hypothyroidism. Because we have low thyroid hormone levels, it can ultimately mess with the body's ability to help us regulate sodium and water balance. W stands for wasting of sodium, like we see in cerebral salt wasting, which happens after a brain injury of either meningitis or trauma. A stands for acute kidney failure, where the kidneys can't filter properly. So this is ultimately going to lead to fluid retention, which dilutes sodium levels, or an inability to excrete sodium correctly, depending on the type of kidney failure that we're looking at. S stands for saline overload, which occurs when we have too much saline being infused, especially if it's hypotonic saline. This excess fluid dilutes the sodium found in our blood, leading to hyponatremia. And lastly, we have H, which stands for heart failure. In congestive heart failure, the heart cannot pump blood effectively, causing fluids to ultimately back up into the body. This fluid retention dilutes sodium levels and leads to hyponatremia, especially in those more severe cases. So what are we going to see when it comes to signs and symptoms? We use the mnemonic SALT, loss. Starting with S, we have seizures. Low sodium levels can disrupt the electrical activity found in our brain, ultimately leading to seizures. This is a more serious symptoms and will occur in severe cases. And for A, we have abdominal cramping. With hyponatremia, it's going to affect the muscle and nerve functions, which can lead to painful cramps in our abdominal muscles. L stands for lethargy, which is a drop in sodium levels, again, that affect the brain. This can lead to fatigue, sluggishness, and a general lack of energy. T stands for tendon reflexes are diminished because low sodium can impair nerve signal transmissions, causing a decrease or sluggish reflex. L stands for loss of appetite. Electrolyte imbalances like hyponatremia can cause gastrointestinal upset. This will lead to nausea as well as a reduced desire to eat. O stands for orthostatic hypotension. A low sodium concentration can lead to decreased blood volume, resulting in a drop of blood pressure while standing up, causing dizziness. Our first S stands for shallow respirations. In those more severe cases, muscle weakness caused by hyponatremia can affect the respiratory muscles, leading to a shallow or labored breathing. And then lastly, we have our last S, which is spasms and muscle cramps. Sodium is critical when it comes to muscle contraction. When levels drop, it's going to cause painful cramps and spasms, particularly in your legs as well as your arms. So what are we looking at when it comes to diagnostic testing? First up, we're going to start with our green tube, and we're going to be looking at serum sodium levels. Really, we look at this to confirm hyponatremia, which is sodium levels are going to be below 135 milliequivalents per liter. And next up, we have our serum osmolality. So again, this measures the concentration of solutes in our blood. So we would typically see a low osmolality, somewhere less than 275, and that's going to confirm that we have some kind of dilutional hyponatremia. Blood urea, nitrogen, as well as creatinine are also important because we need to assess that the kidneys are functioning appropriately, as kidney issues can contribute to hyponatremia. So if we have an elevated BUN and creatinine, it may indicate that we have some kind of hypovolemia taking place. So for the lavender top, again, we're going to be looking at the complete blood count, because this is going to help us identify signs of volume depletion, commonly seen with hypovolemic hyponatremia. If we see an elevated hematocrit, it's going to suggest that we've got some kind of hypoconcentration due to fluid loss. And if we see an elevated hemoglobin, this is also going to indicate that there's some kind of dehydration of water being lost someplace, which is going to lead to our red blood cell concentration increasing. What's a little bit different here is we may even see elevated white blood cell counts, because this can suggest that we have some kind of underlying inflammatory or infectious cause contributing to our fluid loss. For the gray top, we're looking at those glucose levels, because with hyperglycemia, it can actually cause dilutional hyponatremia due to osmotic shifts. And lastly, we have our yellow top or gold top, depending on what it is that they call it at your facility, and we're testing for thyroid levels and cortisol levels. Thyroid levels will help us rule out hypothyroidism with causes like euvolemic hyponatremia, and cortisol levels will help us identify adrenal insufficiency. Sometimes we're going to need some additional imaging to confirm what's going on. So in certain cases, you may see a chest x-ray ordered if we suspect that there's fluid buildup in the lungs, especially if there's fluid overload due to hypervolemic hyponatremia. And of course, if the patient's experiencing severe neurological symptoms like seizure and coma, we're most likely going to be looking at a CT or an MRI to check for brain swelling. So what interventions are we going to be looking at when it comes to caring for these types of patients? We use a mnemonic sodium care to help us remember the interventions. For S, we have safety first. Patients with hyponatremia, especially severe cases, are at an increased risk for confusion, seizures, and falls. Minimally, we want to ensure that their bed rails are up, they have fall risk protocols in place, and their call bell is within reach. For more severe neurological symptoms, we want to prepare seizure precautions like padding the sides of the rails so that we can prevent them from potentially hitting their head in case of a seizure. You may also see a Foley catheter placed to prevent patient harm, but that's usually last case scenario. O stands for observing neurological status. So we want to monitor for signs and symptoms when it comes to confusion, lethargy, and worsening neurological symptoms, as we know, hyponatremia can lead to cerebral edema. By performing these frequent neurochecks, they're going to help us detect early changes so that we're not addressing something too late. D stands for daily weights. We want to weigh our patient at the same time each and every single day to monitor if we've got fluid retention or fluid loss. It's important to remember that 1 kilogram of weight gain is equal to approximately 1 liter of fluid being retained. So this helps us assess treatment is either being effective or ineffective, especially in cases where we have fluid restrictions or hypervolemic cases. Intake and output is going to, again, be extremely important for these individuals because we want to track how much fluid is going in and how much fluid we're getting out. It's also important to remember and understand how fluid restrictions are going to affect our patients. For hypervolemic and euvolemic hyponatremia, implementing these fluid restrictions are often going to help us prevent further dilution of sodium levels. Typically, you're going to see a limit of 1,000 mLs per day. And of course, it goes without saying, we want to monitor sodium levels. Regularly checking these labs are going to let us know which direction we're heading in when it comes to our treatment. And I believe the most important scenario of all is we want to correct the underlying causes, right? We're going to be collaborating with our healthcare team to address the root cause, whether it's fluid overload with CHF, hormonal issues with adrenal insufficiency or SIADH, or maybe just excessive fluid intake like we see with polydipsia. We may need to adjust medications as well as manage diuretics or even treat infections if necessary. Our A is to administer sodium replacements, and that of course is depending on severity. In mild cases, we may just need to increase oral sodium intake through our diet, either with salty snacks as well as broths, but in those more severe cases, we're most likely looking at administering hypertonic saline, which is 3% NaCl, and we give that cautiously. Typically, you only see it in the ICU setting. So here's the deal. When we're treating hyponatremia, sodium replacement must be done cautiously to avoid raising levels too quickly. If we were to do that, it can lead to something called osmotic demyelination syndrome, which is a condition where the brain cells are going to shrink, causing severe neurological damage. The general guideline is to increase serum sodium levels to no more than 6 to 12 milliequivalents per liter in 24 hours and 18 milliequivalents per liter or less in 48 hours. R stands for restricting free water. In cases of SIADH, restricting free water to avoid worsening euvolemic hyponatremia is very important. This doesn't just include beverages, this also includes IV fluids as well. And lastly, one of the most important things that we do as nurses is we educate our patients. We want to make sure that we're teaching them signs and symptoms of worsening hyponatremia, like confusion and muscle cramps, the importance of fluid and sodium balance, as well as even dietary changes to support sodium levels or manage fluid intake. Isn't sodium so cool? It's one of my favorite electrolytes. As always, if you have any additional questions, make sure that you leave them down below. I love answering your questions. Head over to nursecheungstore.com where there's a ton of additional resources and it'll help you ace those electrolytes. And as always, I'm going to catch you in the next video. Bye!